Assalamu alaikum wa rahmatullahi wa barakatuh. Bismillah ar-Rahman ar-Rahim. Thank you, Mr. Chairman, for your kind introduction. My talk will be about the principles of pediatric vascular trauma. As a background, pediatric trauma is the leading cause of death in children older than 1 year in the States. The most common pediatric vascular injury is iatrogenic injuries after interventions. And outside the States and Europe, the warfare, which does not exist or discriminate between the civilians as the combatants, result in significant vascular injuries. This is outside the States and in Europe. This is a case occurring now in front of the whole world by a group of criminals, leading to a massive vascular injuries to the children during that time, during this time. Pediatric vascular injuries are far technically challenging because the certain characteristics of the vessels of the children that they are very small inside, the spasticity of the young of the small vessels, and the ongoing axial and radial growth. The etiology, iatrogenic vascular injury represents more than from 33 to 100% of pediatric vascular trauma, especially in the neonates, which actually around almost 100%. In the 2 to 6 year old patients, 50% are iatrogenic, and older patients, 33% are iatrogenic. The vascular injury during the iatrogenic injuries, of course, because of intravenous insertions, different procedures, umbilical catheterizations, and the non-iatrogenic injuries occurring in the older patients, it occurs in the mainly by either penetrating or blunt traumas according to the areas these patients are living in. There is some pathophysiological consideration that the landmark, anatomical landmarks that we all know in adults, sometimes it changes in children, that there is some sort of overlap between for example, the femoral artery and vein at the groin, leading to inadvertent injection or puncture of the artery if it's not under ultrasound guidance. Another problem is the size of the vessels in the children, that the vessels are smaller and there is high spastic nature. Iatrogenic injuries, whether iatrogenic or traumatic injuries, may lead to either disruption, obstruction, or spasm of the vessels, and downstream ischemia also occurred due to communication between the arteries and veins by these injuries, leading to high output cardiac failure. Of course, the diagnostic evaluation is it will be easier in presence of hard signs of vascular injury. However, the majority of non-iatrogenic traumatic pediatric vascular injury may be that difficult if there is no hard signs, and then we rely on imaging. We can use the handheld Doppler for checking the flow of blood, and the injury extremity index may be useful in that measurement or that detection. The pulse oximetry, especially in blunt trauma, especially in the upper limb with the brachial artery, for example. Duplex can identify the location and severity of injuries, and of course, CT angiography may be helpful in blunt truncal injuries, especially in proximal truncal and stifled arterial injury. But you have to keep into consideration that regardless of the techniques used, if resuscitation, warming, and correction of bony injuries do not correct the malperfusion, we have to go to the OR immediately. And of course, intraoperatively, we can use direct angiography to see the level of the injury and to do completion angiography. Management of pediatric vascular injury, principally, first, of course, we have to rely on the principles of the primary surveillance and simultaneous resuscitation. You can use a temporary vascular chance, can use a pediatric feeding tube. The role of heparin, there is so long, there is no contraindication for anticoagulation. We can use heparin, but take care that the total blood volume in a 3.5 kilogram 2-week child is just 350 milliliter. Non-operative management is conservative measures can be helpful for just minor traumas or minor injuries. And penetrating arterial injuries, we have to the principle, but take care that the vessels are highly spastic and small, and the primary repair can be tried with interrupted non-absorbable sutures, patch angioplasty if in lateral tears, and interposition graft if there is a segment lost. But take care, you have to be an interrupted manner because the running type will lead to narrowing of the anastomosis and causing a purse strings effect. The blunt brachial artery injury, we all facing it, especially with supracondylar fractures, and we can we always or we all see the pink pulseless hand that that the patient may present with a pink pulseless hand, but the blood flow is still going, and there is no major threat on the on that hand. So if it is okay, we can go for conservative measures, but if there is profound ischemia, we have to go for repair. Other methods of treatment in trauma in children, we should keep in mind the liberal use of fasciotomies, and the endovascular techniques may be helpful, but it may be limited because of the small size of the vessels in the children. However, in an older one, we can use it for temporizing to temporize bleeding, just proximal balloon occlusion, like the Ripoa effect. To re-establish the flow to the injured extremity. The adolescent may, thoracic aorta may afford a thoracic stent graft, and also embolization of inaccessible bleeding vessels. To conclude, Mr. Chairman, the pediatric population is facing profound vascular injuries. Mainly, it's iatrogenic in the neonates and small children, but in older one, we have the iatrogenic causes. It's very challenging because the small vessels, the spasticity nature, or the spastic nature of these vessels, and we have to keep all our efforts to save their limbs alive. Thank you.
Thank you very much, Dr. Amr. I think for sake of time, we'll leave the discussion till the end if we have time. And